cancer. It's a word no one wants to hear. But sadly, in 2012 alone, 1,638,910 men and women will hear these words. And just by hearing these words, their whole lives are changed. But cancer research can have just as much change in their lives. For my graduation project, I decided to interview Dr. Russell Anderson. And throughout our interview, I asked him questions about cancer research. I asked him what he knew about cancer research, what has come from cancer research that he has known of, how cancer research can impact a patient's life, and also I asked him how cancer research funding could be better distributed to better benefit the patients and come up with better treatment options for the patients.
I'm Dr. Russell Anderson. Some call me Rusty. I have been a cancer doctor now since 1990 and enjoy practicing here in Smithfield, North Carolina. This is a Duke Oncology Network cancer clinic.
How long have you been working as an oncologist?
Well, I finished my training in oncology in 1990, so that would be 22 years.
What are some of your responsibilities as an oncologist?
Well, we're involved with all aspects of cancer patients. Sometimes at the very beginning, before a diagnosis is even made, we get involved. More often, though, we see patients once cancer has been identified. So we're working at that point to stage the cancer, determine how far it may have spread, and at the same time determine the best way to treat it. Early stage cancers are treated more with surgery. More advanced cancers require chemotherapy. Once the stage is set, we're involved with treating cancers. Early stage cancers that are treated with surgery sometimes still require chemotherapy to improve the cure rates. Advanced cancers require chemotherapy, sometimes for cure, but more often than not just to prolong survival without cure. And then we're involved in the terminal phases and comfort care, helping with pain treatment and other comfort measures.
So that sounds like a lot.
Yeah.
Okay.
I'm also a hematologist, so
Wow.
we're treating patients with blood and blood clotting disorders.
Okay. So what are the ranges of cancers that you see typically?
Well, here in the community we see all cancers. We don't specialize in any particular cancer, though many require very high levels of technology that could only be offered at a university. We see a lot of breast cancer, colon cancer, a lot of lung cancer. We see lymphomas, myelomas. We help out with some of the gynecologic cancers, uterine and ovarian cancers, bladder cancer, brain cancer, you name it, we see it.
We see it all.
Acute leukemias would be an example of something we don't treat here. That requires specialty trained staff in an inpatient setting that's dedicated to doing that kind of treatment.
Okay. So what do you know about cancer research?
Well, a fair amount. I was involved in research, both at the bench and now in clinical research throughout my career. Most cancer doctors in training are involved in some research. I was involved after training for about 7 years doing bench research.
Okay. So that answered my next question. Have you ever participated in any research? What do you know about funding for cancer research?
I wrote a lot of grants in my day. I was better at getting grants funded than at actually doing the research and writing papers, and that's part of the reason why I focus now on treating patients rather than bench research.
Okay. Do you know more or less how the NCIH, is it? NCIH?
Well, there are different funding agencies. The National Cancer Institute, which is part of the NIH, National Institute of Health, is a major funding funder for cancer.
Right.
But then there's the American Cancer Society, and there are other private funding agencies.
How would they divide up the funding for cancer? Would you know?
Well, the allotment of funds is based on the proposals and how good they are to the people who review the proposals. Investigators with a good track record in research are more likely to get funding because they've done well in the past.
Right.
But they're also good at funding young researchers to try to get them going. It's once you get past that initial stage before you're a super successful researcher that it can be hard to get funding.
So I read that the National Cancer Institute, that for the most part they have to come up with their plan for research. Most of the times it's based off a need, whatever research they have or have not, and then they have to get that approved by the government. So is that true?
Yeah, the National Cancer Institute and the review committee that meets to review these grants, they're the ones who decide which ones have the best merit and are the ones that will get the available funds. Now, in good years, there's lots of money available. When the economy's tight, then funds are limited.
Do you agree with how they divide up the funding for cancer research? Do you think they have a pretty good system in place?
Yeah, I'm not sure necessarily how to do it better. I guess what I would disagree with is sometimes big cancers or things that the public is interested in seeing funded may get more funding, whereas great ideas that aren't necessarily for a specific cancer or a popular cancer may not get funded. So a lot of the breakthroughs in science aren't, in breast cancer specifically, aren't from research on breast cancer. They're very basic things that no one would have imagined could have been applied to breast cancer 10 years later.
So you feel media has a lot to do with how some of the cancers
Yeah,
get
I think so. But on the other hand, if that generates more funding, then we've got to live with that.
For my research paper, I compared funding for endometrial cancer versus breast cancer, and that was one of the arguments that they were able to get more funding because of the emotional appeal for women and the media behind it.
I think that's true, but I would say 90% of the work at the basic level on breast cancer is also going to be applicable to endometrial cancer.
Okay. So the next question I had is, in 2010, the top 5 cancers that received the most funding were breast cancer, prostate, lung, colorectal, non-Hodgkin, and non-Hodgkin lymphoma. Would you agree that these needed the most funding?
Not necessarily. Something unrelated to cancer may generate the breakthroughs. On the other hand, research done on those cancers may be applicable to other cancers. So I can't complain too loudly.
Okay.
I think the best ideas should be funded and not necessarily the major cancers.
Okay. So the next question was that in 2010, the cancers that received the least amount of funding were endometrial, thyroid, bladder, and kidney. Do you agree with those receiving the least amount?
If a kidney cancer researcher had a great idea and it wasn't funded because it was kidney cancer, I wouldn't agree with it.
Okay.
So, yeah, again, it's not necessarily the cancer, it's the idea.
Okay.
Those aren't the major killers, so at the level of clinical research, I suppose, it's reasonable to fund the bigger killers.
Right.
I think I personally would lead towards funding more basic research rather than clinical research. I think that's probably the path to eventual cure.
Okay.
But we get important information from funding all levels, clinical, translational from, that's research from the bench to the patient, and the very basic. All need to be funded. The best ideas should be funded.
Okay. So that pretty much answered my next question. How do you think it should be divided up? So you believe more basic research versus focusing more on one specific type of cancer? Because the basic research in the end could, I guess, provide a stepping stone for better treatment for the bigger cancers?
Cancer is a big problem which we still don't fully understand. We need to know how cells work normally and when they're cancerous. Doesn't matter if it's a breast cancer cell or whether it's a normal breast cell. So many basic things we still don't really understand, and it's that, I think, that will eventually bring durable, less toxic treatments and cures.
So my next question is, how big of an impact do you think cancer research has on a patient's life?
Well, it's had a huge impact. One example is in chronic myelogenous leukemia. When I was in training, the average lifespan was about 4 years with someone with chronic myelogenous leukemia. And with research that did focus on that particular cancer, a drug called Gleevec was identified about 15 years ago, which has turned chronic myelogenous leukemia into from a killer into something you can live a normal lifespan with. So that basic research has led to one disease that is almost cured.
Do you have any other experiences like that that you could tell us about?
Well, you could name things in any cancer. Lung cancer, for example, is the leading cancer killer. The focus of research there has been trying to find out what makes different lung cancers sensitive or refractory to therapy. And in many cancers, especially the ones in non-smokers, there's a mutation in the EGFR gene, epidermal growth factor receptor gene, and 50% of those patients with the mutation will have an amazing response to an oral drug called Tarceva, which was identified through basic research about 10 years ago. Still nowhere near a cure for everyone with lung cancer, but in that subset of patients, many enjoy a previously unimagined response.
Okay. Is there anything you'd like to add about cancer research, cancer funding before we end?
Well, it was the research and the rapid breakthroughs that kind of attracted me to the cancer field. And I haven't been disappointed. Year after year, there are incredible breakthroughs.